everybody, and thank you for joining us today. My name is Steve Hall, and I am a fourth-year nursing student.
And I'm Kristen Hawes, a nurse scientist and assistant professor at the College of Nursing at the University of Saskatchewan, and an affiliated researcher with the Saskatchewan Centre for Patient-Oriented Research. Today we are here to share with you our preliminary findings from CARDS.
CARDS, as in the Cancer and Aging Research Discussion Sessions, a patient-oriented research initiative.
Older adults with cancer have unique needs, experience high symptom burden, and are faced with many difficult medical decisions.
Aging is one of the most important risk factors for cancer, and with the growing number of older adults worldwide, health systems face a growing challenge to meet the needs of this important and distinct population.
Due to the aging population and increasing numbers of people with pre-existing comorbidities being diagnosed with cancer, health systems and healthcare professionals must prepare to care for and optimize the patient experience for this unique population.
Patient-oriented research is a growing trend in health research. Instead of researchers trying to think about what to investigate next, we go to the patients and involve them in setting research priorities, conducting projects, and analyzing data.
The ultimate goal of patient-oriented research is to shape health research by shifting the role of the patient from a passive receptor of services to a proactive partner.
So we are pleased to introduce our patient partner, Margaret Thompson.
I'm Margaret Thompson. I'm a senior who was diagnosed with cancer and have had several different kinds of treatment, including a stem cell transplant. I believe the most critical difference between patient-oriented research and other types is that you're doing research with older adults instead of research on older adults.
We held 3 focus groups, 2 in Saskatoon and 1 in Regina. Using a qualitative descriptive approach, we asked older adults with cancer and their care partners to discuss what they found helpful and what they were lacking during 3 time points: pre-treatment, treatment, and post-treatment survivorship.
Margaret was instrumental in designing and running the process and co-led the discussion groups.
I was one of them. I spoke their language and they trusted me because I understood where they were coming from. It's all about gathering lived experiences. You're part of your community and understand the culture and ways of speaking.
Data collection is ongoing. At this time, we are conducting one-on-one, semi-structured phone interviews with participants who volunteered to contribute to the study further.
The top priorities that came from the focus groups are as follows: desire for enhanced patient education strategies addressing multimorbidity and aging-sensitive needs, improved patient-provider communication, tangible and accessible survivorship support, support for carers, and the option for technology-based solutions.
There were many differences in the level, style, and quality of communication that participants had with their healthcare teams.
As well, many participants who were unhappy with their care noted that they felt as though there was a power imbalance between themselves and their care providers. Another issue with communication was having to re-explain the same thing to different people. For example, you're first assessed by a nurse, then a social worker, then a medical resident, and then the attending physician. Participants felt as though there should be some way to facilitate a smooth transition of care between the various professions and departments.
One idea that was brought up in the discussion sessions that was very popular among the participants was the use of a tape recorder during all appointments.
Using a tape recorder not only gives you an accurate record of what you were told, it can let you hear what you could not hear after receiving bad news.
Participants generally stated that a support person with them in all of their appointments is essential. However, not everyone had access to a support person.
I found most people that were there had a support person. I never took anybody with me. I always have gone myself, and I think part of the problem is I've always had to deal with things myself.
There is a unique subgroup of older adults with cancer who are also caregivers. This is an especially vulnerable population as they have people who depend on them and then suddenly have increased care needs themselves.
First, you're diagnosed with cancer, and then you have to put your husband in long-term care. I had no intention of ever putting him into long-term care.
Our findings identify a need for additional psychosocial support, as well as facilitating additional care for their loved ones.
I think the role of caregivers is critical. I wouldn't have wanted to go through this without my husband, and we've got 2 kids in town, but they work. And I suppose I could have asked a friend to go with me, but I think it's important to have somebody there, and he was there at all of them.
By capturing lived experience, we capture the powerful language used to express it.
Our next steps from here are to share findings with decision makers and pursue future research based on these priorities.
Although analysis is preliminary, one thing is clear.
Older adults want to be involved in setting priorities for care in cancer.